Stacked ABR can be used to help diagnose acoustic neuroma and some other tumors, especially when the tumor is small in size. This slide shows how to use stacked ABR to help identify a tumor, for example. On the left-hand side, we have normal side. This we use standard ABR, click evoked only. And we have ABR wave here. ABR wave amplitude is this. And on the right-hand side is the standard ABR. And this is a known confirmed patient with tumor. So ABR wave is here. If we use standard click evoked ABRs, I mean on the tumor side, the wave is reduced. It is, but the difference is from here on the left-hand side to here on the right-hand side. So I mean, on the left-hand side, the normal side, we do see a PEM artifact, and yeah. So just so you know, at this point, you probably have seen a lot of PEM artifact in your lab exercises. So you should be able to identify this is a PEM artifact, and again, due to the latency thing. So the purpose here is to show the stacked ABR and how to use it. So stacked ABR here, now we have ABRs derived response, derived band ABRs here. Each waveform here is derived response. Is a recording by using clicks together with high pass noise at different color frequencies, 11.3 thousand hertz, 5.7 thousand hertz, 2.8, 1.4, 0.7 thousand hertz as the color frequency for the high pass noise. And we move the waveforms, each waveform, so that the wavefiles are all aligned, and we add them all together, and that gives us a very big wavefile here. So this is a stacked ABR on the normal side, non-tumor side. This side is normal, has no tumor. We have a very big stacked ABR wavefile amplitude. However, on the tumor side, if we do the same thing, we align the wavefile, all the wavefiles, add them all together, the stacked ABR amplitude is here. So as you can see, the amplitude reduction from the left-hand side is 722 nanovolt to the right-hand side, which is 357 nanovolt. The reduction is dramatic, nearly cut in half. The amplitude was really cut in half. So this is a comparison of using the standard ABRs or stacked ABRs on normal versus tumor side recordings. We usually would suspect tumor if the stacked ABR amplitudes are decreased too much, or if the stacked ABR amplitudes are not symmetric between left and right ears. So these are the theories. The theory is that this stacked ABR may be more sensitive to small tumors than standard protocols. So that's the idea of using stacked ABRs to detect tumors, especially small tumors. This slide shows how to use stacked ABR to help identify tumors in clinical settings. On the top panel, it shows the stacked ABR wavefile amplitude for people with no tumor, normal, plotted with open circles, and the mean value. The mean stacked ABR wavefile amplitude for males is about 875 nanovolt. And on top is the mean plus 2 standard deviation, and bottom is mean minus 2 standard deviation. And this figure also shows the stacked ABR wavefile amplitude for people with confirmed tumor. And my apologies, those confirmed tumors were plotted as field symbols, and they all fall within the shaded area, which is smaller than mean minus 2 standard deviation. So, and this is what they found for men. For women, the similar findings are observed. The mean stacked ABR wavefile amplitude for females is about 920 nanovolt. On top here is the mean plus 2 standard deviation, and here is mean minus 2 standard deviation. And for patients with confirmed tumor, and again their symbols are plotted within the shaded area, which is not shown very well on the figure I copied. My apologies for that. So for men and women, similar findings were found. In patients with no tumor, normal people, for men, the mean stack ABR wave 5 amplitude is about 875 nanovolt, and for females, the mean stack ABR wave 5 amplitude is about 920 nanovolt. There's no need to memorize these two numbers. It's just the numbers coming from studies and listed on a book figure. Excuse me. And also, if you look at the interoral differences for these patients, which is data are not shown on the figure, they are less than 10%. So as long as the PTAs do not differ more than 10 dB, the interoral differences of the stack ABR wave 5 amplitude should be less than 10% for people with no tumor. On the other hand, for patients with tumors, there are two red flags in terms of stacked ABR wave 5. First is the stacked ABR wave 5 amplitude likely will be less than the mean minus 2 standard deviation. Second is the interoral difference between the stacked ABR wave 5 amplitude likely will be greater than 10%. So these two are the indicators that will help us diagnose tumor by using stacked ABR. So even though stacked ABRs can be useful to help identify tumor, there are some criteria we have to exclude. There are some subject excluding criteria we have to consider. If the subject has conductive or mixed hearing loss, those norm data will not apply. And also, if the subject has flat sensory neural hearing loss and is greater than 60 dBHL, then the ABR wave 5 is not going to be very big. So when you add them together, it still is a very small stacked ABR wave 5 amplitude. Also, if the patient has residual hearing only at the low frequency region, and that will compromise the stacked ABR performance as well. Or if the patients have neurological disorders such as multiple sclerosis, head trauma, and so on, those will affect the accuracy of stacked ABRs. Or in patients with hyperacusis. Hyperacusis usually is a result of recruitment. I should say abnormal recruitment. So when the sound becomes louder, we should recruit more neurons. That's normal. But some patients, they recruit too many neurons. So the increment of recruitment for neurons is way too much compared to the increment in the stimulation. So for those for these conditions, for this patient, these kinds of patients, they do not, stacked ABRs do not work on them. So we need to exclude them. So this is a summary slide for stacked ABR to detect tumor. Stacked ABR software is available clinically. However, the major drawbacks are it's very time consuming because it is based on derived band ABR recordings. As you know, derived ABR recordings are time consuming. And it requires very quiet subjects, because if the subject is noisy, then you don't get good ABR recordings, especially in the different masking noise conditions. So these are the two major drawbacks for stacked ABRs. The last point is whether stacked ABR can compete with MRI or to detect small tumors really is a debate. So I would say if I were the physician, I would go with MRI, which is more precise. However, for audiologists, you do need to understand that stacked ABR can be used to help us identify tumors. As an audiologist, we don't have the power of prescribing MRI yet, but we do have the power to record ABRs and stack ABRs to help us identify patients who potentially may have tumors. We can then refer them to neurology for further evaluation.